Hello, I'm Dr. D. Narendra Babu, pediatrician and neonatologist at Akkineni Hospitals. Wishing you good health. We'll be covering some essential points today. Do follow along and jot them down.
Pediatric acute tonsillitis is one of the most common drivers of antibiotic prescriptions worldwide. Yet, in practice, a vast majority of these patients receive medications that offer no biological benefit. Most cases are viral. Pathogens like adenovirus, rhinovirus, parainfluenza, and the Epstein-Barr virus are the primary etiologies driving the infection. This chart breaks down the true distribution in children aged 5 to 15. Up to 80% of cases are strictly viral, leaving only a 15 to 30% minority caused by a specific bacteria, group A streptococcus. When clinicians prescribe empirical antibiotics for those viral cases, they expose children to unnecessary risks, including adverse pharmacological side effects. The harm also extends systemically. Unnecessary prescriptions disrupt the developing pediatric gut microbiome and accelerate the global antibiotic resistance crisis. The clinical focus on Group A streptococcus, or GAS, exists independently of the patient's immediate discomfort. Antibiotic intervention for GAS aims to prevent systemic complications that can manifest long after the initial infection has cleared, regardless of the immediate throat pain. Effective management requires algorithmic precision. Isolating the specific bacterial minority ensures antibiotics are reserved for cases where they provide genuine protection against long-term disease. When a true Group A streptococcus infection is left untreated in a susceptible individual, it triggers a destructive immune response. The mechanism driving this destruction is a pathophysiological concept known as molecular mimicry. On the left is the streptococcal M protein. On the right are human cardiac tissue proteins. Notice their striking structural resemblance. Because of this similarity, the host's immune system generates cross-reactive antibodies that erroneously attack the body's own cardiac tissue instead of just the pathogen. The immediate clinical result of this autoimmune assault on the heart valves is rheumatic carditis. If streptococcal infections repeatedly go untreated, the patient suffers recurrent rheumatic attacks. This produces cumulative damage to the valves that eventually necessitates surgical repair or full valve replacement. Strict adherence to evidence-based diagnostic algorithms is the only reliable method for intercepting this pathophysiological cascade. By treating GAS accurately, clinicians prevent lifelong rheumatic heart disease. To accurately estimate the probability of GAS without immediately running lab tests, clinicians utilize an evidence-based gateway known as the Modified McIsaac Scoring System. This checklist calculates a patient's risk based on distinct clinical features. The score increases by 1 point if the physical exam reveals tonsillar exudate, visible white or yellow patches on the tonsils. Another point is added for tender anterior cervical lymphadenopathy, identifying localized swelling in the lymph nodes at the front of the neck. The system accounts for symptomatic criteria as well, adding a point for a documented fever over 38 degrees Celsius, and another point for the notable absence of a cough, since coughing strongly indicates a viral etiology. Finally, demographic modifiers adjust the baseline. Being between the ages of 3 and 14 adds a point, while age 45 or older subtracts a point from the total score. This cumulative number dictates the immediate clinical response, beginning with the lowest risk tier, a score of 0 or 1. At a score of 0 to 1, the statistical probability of a Group A streptococcus infection is less than 10. You confidently exclude GAS, perform no rapid testing, and prescribe no antibiotics. By acting as a strict gatekeeper, the McIsaac score effectively strips away the lowest risk patients, preventing millions of unnecessary tests and the subsequent overprescription of antibiotics. This branching decision tree outlines the protocol for higher McIsaac scores. Patients scoring a 2 or 3 fall into a 15 to 35% probability range, which mandates diagnostic verification via testing. The required test is the Rapid Antigen Detection Test, or RAT. It acts as the definitive arbiter for moderate scores, delivering results in 5 to 10 minutes with roughly 85 to 90% sensitivity. For the highest scores of 4 or 5, the probability of GAS jumps to 50 or 60%. Clinicians can choose to confirm with an RAT, but this high probability clinically justifies initiating empirical antibiotic treatment immediately. However, Even with high scores, clinicians must remain vigilant for specific red flags pointing toward the Epstein-Barr virus, the pathogen responsible for infectious mononucleosis. Physical exam findings unique to EBV include bilateral posterior cervical lymphadenopathy, swelling in the back of the neck rather than just the front, along with extreme fatigue and an enlarged liver and spleen. Mistaking EBV for gas carries a severe pharmacological consequence. In this split-screen diagram, we see the specific reaction that occurs if a patient with EBV is prescribed amoxicillin. 95% of EBV patients given amoxicillin will develop a florid, highly distressing maculopapular rash. Algorithmic differentiation conserves antibiotic efficacy and protects patients from severe iatrogenic harm. Once a group A streptococcus infection is positively confirmed, the immediate clinical objective shifts to targeted bacterial eradication. For pediatric patients, the modern pharmacological standard is amoxicillin, dosed at 50 milligrams per kilogram per day, divided into 2 doses. The most critical aspect of this treatment is completing the entire 10-day duration, regardless of how quickly the child's symptoms resolve. Halting the medication early causes unacceptably high rates of bacterial eradication failure. If the bacteria survive, the antibiotic course fails its primary objective, reliably preventing rheumatic fever. For patients with documented penicillin allergies, clinicians have proven evidence-based alternatives, specifically azithromycin or clindamycin. Pharmacological success against gas requires selecting the correct molecule and maintaining strict, unyielding adherence to the 10-day duration to guarantee complete pathogen eradication. While tonsillitis is generally localized, medical emergencies occur when the infection breaches the tonsillar capsule and invades the deep spaces of the neck. This cross-section illustrates a peritonsillar abscess, clinically known as quinsy. It is a dense collection of pus that forms specifically between the tonsil capsule and the superior pharyngeal constrictor muscle. Quinsy presents with highly distinct clinical signs: severe throat pain isolated to one side, a muffled hot potato voice, and trismus, which limits the patient's ability to open their mouth. A telltale visual indicator is the uvula deviating sharply away from the affected side. This physical blockage requires immediate aspiration or an incision and drainage procedure. Deeper within the neck, a retropharyngeal abscess can form. This specific infection is much more common in younger children. Patients with a retropharyngeal abscess will present with high fever, neck stiffness, heavy drooling, stridor, and a rigid refusal to move their neck. Because of its location, a retropharyngeal abscess is an immediate airway emergency. It demands urgent CT imaging of the neck and rapid surgical intervention to secure the patient's breathing. Recognizing these exact anatomical presentations allows clinicians to instantly escalate a patient from primary symptom management to critical, life-saving surgical care. When patients suffer from chronically recurrent tonsillitis, clinicians must evaluate their historical data for definitive surgical intervention, the tonsillectomy. The decision to surgically remove the tonsils due to infection is governed by a strict threshold known as the Paradise criteria. This timeline graphic maps out those specific thresholds. Surgery is indicated if a patient experiences 7 documented streptococcal episodes in a single year, 5 episodes per year for 2 consecutive years, or 3 episodes per year over a 3-year period. Surgery is also indicated independent of infection if the patient experiences obstructive tonsillar hypertrophy, meaning the tonsils are physically large enough to cause sleep-disordered breathing or difficulty swallowing. Managing pediatric tonsillitis requires a disciplined clinical workflow. Clinicians use the McIsaac score to determine the probability of GAS, verify moderate cases with an RADT, and aggressively eradicate confirmed bacterial infections with a full 10-day course of antibiotics. This approach relies on the discipline to withhold antibiotics for the 80% of patients suffering from viral infections. Executing this evidence-based algorithm protects the individual child from the lifelong damage of rheumatic fever and safeguards global public health from the threat of antibiotic resistance.